thank you very much. So I'd like to thank Astro, and in particular Dr. Howard Sandler, for the invitation and the opportunity to present to you today. Actually, it's a tremendous honour for me as an Australian to be here presenting in front of you, the Astro membership in the Presidential Symposium. I'm truly grateful for the invitation. The talk charged to me today is talking about SABR for primary RCC, and the question is, ready for prime time? So to begin with, I think it's important that we actually define what it is that we mean by prime time. Prime time to me means being on the centre stage, being in the mainstream, being in the spotlight. And in the context of SABR for primary RCC, I believe that this means that we should be able to talk in our multidisciplinary tumour boards and amongst our colleagues that for SABR to be a standard treatment option that we can offer patients who come in with primary RCC. In order for us to reach that billing in prime time, I think there are several key enablers that we need to discuss as a community. One is to understand the history and the evidence for SABR in primary RCC, to understand the dose and fractionation schedules that are possible, to understand the role of post-radiotherapy biopsy, the role of SABR in the solitary kidney, and understanding some of the optimal follow-up schedules. As a background, the worldwide incidence of RCC is increasing, and this is most rapidly increasing in the age group above the age of 70. In fact, this age group has a 3.8 times increased cancer-specific mortality as compared to patients who are younger than 70 years old. Partially the reason for this is the increased use of cross-sectional imaging in the abdomen in the community, picking up incidental primary RCC. The current standard of care for primary RCC is surgery, and this is ideally nephron-sparing surgery. There are, however, limited curative treatment options for those patients who are technically high risk for surgery or are medically inoperable. These alternative treatments include thermal ablation, and this can be either radiofrequency ablation or microwave ablation, which is superheating, or cryoablation, which is supercooling. And these alternatives are limited by reduced efficacy when the tumours are greater than 3 to 3.5 centimetres in size, and also increased complication rates for larger masses. If we had to look at how these treatments work, generally they can avoid a general anaesthetic, except cryoablation often does require a general anaesthetic. But it has challenges with thermal ablation of perihilar tumours. This is because the renal vessels act as heat sinks, drawing away the thermal energy. And it also has challenges with larger tumours, with increased complication rates, reduced efficacy, and still invasive. And in this context, it may be that SABR or SBRT is an alternative that ticks all of the boxes. It has a capacity to avoid a general anaesthetic, it can treat perihilar tumours, it can treat larger tumours, and it's totally non-invasive. However, there is a widespread conception that renal cell carcinoma is radio-resistant. And this has been long held and standing within traditional teaching, even current day. And this has been propagated by 7 randomised trials that were conducted in the era of post-operative radiotherapy after a prior nephrectomy. This included over 700 patients, and in summary, they showed a reduction in local regional failure rate, but no difference in overall survival. This may be partially explained by the treatment techniques that were used in the 1980s when treating primary kidney cancer. This is a hand-drawn 3-gig conformal plan indicating that there is increased high-dose areas or hotspots within the renal bed. And this is exactly the area where the small bowel and large bowel falls into the renal bed after a nephrectomy. So higher rates of complication and no translation into overall survival benefit. Furthermore, there were cell survival assays and surviving analyses performed almost 3 decades ago from Stanford. And this is a cell survival assay looking at surviving cell count in the y-axis on a logarithmic scale, and on the x-axis looking at dose and radiation. These are the 2 most common human renal cell carcinoma cell lines, the A498 and CARCI1 cell lines. At doses of 2 grade per fraction or less, there's actually a shoulder on the survival curve of these 2 cell lines, indicating there's only a small fraction of cell killed. But when we're talking about higher doses, so 6 grain above, these are logarithmic cell kills, indicating that yes, maybe renal cell carcinoma is resistant to conventional radiotherapy, but may be sensitive to higher doses per fraction. We're also recognising that there may be alternative mechanisms of cell kill when using high dose per fraction SABR. This includes endothelial apoptosis, engagement of ceramide and sphingomyelinase-induced cell death pathways, and also pro-inflammatory signaling that may be conducive for adaptive immunity. When considering the evidence, actually the timeline for SABR in primary RCC is much longer than we expected. The first reports of fixed-frame SABR were emerging from the Karolinska Institute in 1995. Only a few short years later, in 2003, was the first report of SABR for primary RCC. In 2008, also from the Karolinska Institute, was the first report of patients receiving SABR for primary RCC in the context of a solitary kidney. The International Radiosurgery Oncology Consortium of the Kidney produced an international consensus statement in 2016, and most recently the TROG 1503 Fast Track 2 trial. Alright, so let's cover off one of these key enablers that we need to reach prime time, and one of this is understanding the evidence that we have for stereotactic radiotherapy in this setting. This is a table that's adapted from the ISRS prospective guideline and systematic review published in January of this year. And this is a table of all of the prospective trials for SABR in primary RCC. You can probably appreciate that these are all uniformly small single institutional studies with a range of dose fractionation schedules used, good control rates, and loss of eGFR in that range of about 10 to 15 mils. When we compare this evidence to thermal ablation, by the end of 2023, there are already over a dozen prospective trials versus 0 prospective trials for thermal ablation. There are 265 patients enrolled into these clinical trials, and the efficacy is comparable to that of retrospective data for thermal ablation, but it's important to note that there's no retreatment rates. Approximately 10% consistently of thermal ablation data has retreatment events that is still considered potentially successful. And nephron sparing with renal function is comparable to that of partial nephrectomy. So when we're comparing the data, I hope you agree with me that when we're weighing them up, it's the elephant that's the SABR and the mouse that's thermal ablation. The Trans-Tasman Radiation Oncology Group 1503 trial, Fast Track 2, stands for Focal Ablative Stereotactic Radiotherapy for Cancers of the Kidney. This was published in March of this year. And this is a multi-centre phase 2 trial. It's first of its kind. It included patients with a median size of 4.6 centimetres with primary RCC, so relatively large. All patients were biopsy confirmed, and in fact 70% of the patients had serial growth prior to enrolment, indicating a failed period of active surveillance and potential biological aggressivity of the cancers. And patients received either a single fraction or 3 fractions of SABR. This was a study that recruited in 7 centres in Australia and 1 centre in the Netherlands, and recruited 70 patients between 2016 and 2020. The distribution was 2/3 male and 1/3 female, which is represented in this population of patients. The key eligibility criteria that patients needed to be either medically high risk or inoperable for surgery, a multidisciplinary decision that active treatment was warranted, was required, and an eGFR minimum of 30 mils per minute. The tumour was not allowed to abut the bowel, and the maximum tumour size allowable was 10 centimetres. This was a comorbid population with an average age of 77 and a BMI of 32, and again 70% of the patients had serial growth prior to enrolment. The distribution of disease, only 1/3 of patients had T1A disease, and this is the population that may have been amenable to thermal ablation. However, the rest of the population had larger volume and more extensive primary disease. Headline figures at a median outcome, median follow-up of 43 months. The local control rate was 100%, cancer-specific survival 100%, freedom from distant failure 97%, and average kidney function loss 14.6 mils. These data is actually quite consistent with longer-term data, and this is a publication from IROC with an individual patient data meta-analysis of 190 patients across 13 institutions and a median follow-up of 5 years. Again, larger tumours, and at 5 years the cancer-specific survival was 92%, the local failure rate was 5.5%, distant failure rate 10%, and GFR loss 14 mils. Very consistent with the data from that prospective trial. Alright, so now we've addressed the data behind what we're looking for reaching that prime time billing. Another question is, what is the optimal dose fractionation regimen? Also from the IROC series, there were 81 patients who received a single fraction, approximately 42% of the patients. Single fraction SABR was associated with reduced risk of local failure and improved progression-free survival when comparing to multi-fraction SABR. And this was true in the multivariable analysis when adjusting for factors such as ECOG performance status, patient age, and tumour size, that multi-fraction SABR had a higher risk of local failure. Very provocative and hypothesis-generating data. At the Peter MacCallum Cancer Centre since 2012, we've been using a single fraction of 26 gray for tumours less than 4 centimetres and 14 gray by 3 fractions for tumours greater than 4 centimetres. And there's a biological rationale for this, because as you recall that those 2 human renal cell carcinoma cell lines, the A498 and CARCI1, they have an alpha-beta ratio of 2.6 gray and 6.9 gray respectively. And these 2 schedules are absolutely iso-effective for these 2 cell lines. So with the present level of data, single fraction SPRT between 25 to 26 gray appears to be a favourable regimen. A dose between 42 to 48 gray in 3 fractions is also reasonable and has been used in prospective trials. And if a 5 fraction regimen is used due to difficulty in meeting the organ of risk constraints, 40 gray in 5 fractions could be reasonable, just with the caveat that there is some suggested data that control rates might be lower. Another key enabler is understanding the role of post-treatment biopsy. Now, this is an important factor for determining success in thermal ablation. This editorial that was written after a recent study published by UT Southwestern that was using post-radiotherapy biopsy suggests that post-radiotherapy biopsy of surgical dissection has been discarded in the treatment paradigm for many other malignancies treated with radical radiotherapy. If you think about it, this is true for head and neck cancer, lung cancer, cervical cancer, and prostate cancer, but the role of post-treatment biopsy has been discarded almost 20 years ago in the oncological community. The investigators from UT Southwestern, Dr. Nan and colleagues, showed that despite having a positive biopsy, there was reduced cellularity, a reduced Ki-67 index, and at a transcriptomic level, there was engagement of senescence and apoptotic pathways. Dr. Tang and colleagues, also from Texas, showed that local control rates were 92%, but despite this, 57% of biopsies were positive at 3 months. Again, though, the proliferative index was low at 6%. And from Cleveland, Grubb and colleagues showed that there was a positive biopsy rate at 6 months, despite a phase 1 dose escalation study, even to eye-watering doses of 60 gray in 3 fractions. So, given that a positive biopsy does not predict for subsequent local tumour and distant progression, it's only recommended when imaging findings are concerning for progression. So as a summary, do not biopsy after SABR outside of a clinical trial. And this is really important to communicate to our multidisciplinary colleagues that this is not something that we should be doing standardly. In contrast, pre-treatment biopsy is recommended, and that's important for us to make sure that we are treating malignant and aggressive disease. A further point I'd like to touch on is what is the role of SABR in a solitary kidney. This is often a presentation when we have a patient who's had a prior nephrectomy and presents with a new kidney mass. From the IROC data, there were 56 patients out of the 190 that had a solitary kidney in play. And when we're looking at in panel A, local failure, and panel B, cancer-specific survival, and panel C, progression-free survival, there's no difference in oncological outcomes when patients have either a solitary kidney or 2 kidneys and presenting for the indication of SABR. When we look at kidney function, which is really important, 5 years after SABR, a solitary kidney has been associated with reduction in EGFR by about 14.5 mils. It's compared to 13.3 mils in those patients with 2 kidneys. And there are similar rates of post-SABR dialysis, 3.6% versus 3.7%. So both from a kidney function aspect and oncological outcomes, it's certainly not a contraindication if someone presents with a solitary kidney and requires treatment. It is, however, important to keep a track on renal function, and as part of our initial pilot study at Peter Mac for Fast Track, we performed serial DMSA SPECT-CT and calculated GFR using chromium-51 nuclear medicine tests. And this is an example of a patient with a solitary kidney and a 4 centimetre endophytic mid-pole tumour. What can be observed is that after time, in the high dose regions and the intermediate dose regions, there's loss in uptake in the renal parenchyma, indicating that we see loss of kidney function in these areas. And we map this out, and we can do that for both the 26 gray in 1 fraction arm, the 42 gray in 3 fraction arm, and a biological equivalent dose calculation on the right panel from that initial 33 patient study. It's very similar, and there's a pattern that emerges. So beyond 100 grade BED, it appears supralethal for renal function. Below that point, there's lots of gains that can be made in terms of sparing kidney function. So generally speaking, trying to be as conformal as possible with those intermediate doses is the key to be able to preserve renal function. So for patients with a solitary kidney, patient and treatment factors are important. It's really important to refer to a renal physician to manage medical comorbidities and CKD. And it's important that caution is advised with CKD classes 4 and 5. What I mean by this is eGFRs less than 30 mils per minute. In these kind of instances, shared decision making is very important due to the potential risk of dialysis. And there are technical considerations also to reduce the volume of radiated kidney, particularly that intermediate dose wash, or we would like to call it the conformality or R50% conformality index. The final enabler I think I'd like to touch on is to understand what is the optimal post-treatment follow-up schedules in patients receiving primary SBRT to the kidney. This is a table that's been adapted from the Fast Track 2 trial. A CT scan of the thorax and abdomen is really important to assess for both local and distant progression, the lungs being a common site of progression. Regular blood tests looking at eGFR is also important and should be conducted frequently. We also suggest a split function test at the beginning of treatment to assess kidney function and differential kidney function, but also progression to potentially look at potential salvage options at that time. Now it's important to note with the cross-sectional imaging, there's no table here or indication of any scan before 6 months. This is because at 3 months' time, a pseudo-progression after SABR for primary kidney cancer is actually quite a common phenomenon. Also, we're expecting that as response should actually occur over many, many years. And this is something that we've seen repeatedly in the literature. This is data on the left from Cleveland and on the right from Japan, showing that patients have ongoing tumour reduction for many years, and when talking about RCC criteria, are still tipping into partial RCC response, even years post-therapy. Another issue to consider is that contrast enhancement is a measure of success post-thermal ablation. However, for us in SABR, it's not yet a useful indicator. This is a study from Boston showing that 38 out of 41 patients had local control, so 92% local control. And these are contrast enhancement characteristics. In the purple line, it's looking at unenhanced quarter-megakaryotic phase, early nephrogenic phase, and late nephrogenic phase. And in fact, after SABR, which is the blue line coming up here, all of the contrast enhancement characteristics are higher after treatment rather than lower. And this is showing, again, that contrast enhancement, as opposed to physically destructive thermal ablation, is not the measure of success we should be using in radiotherapy. So, RCC measurement is still standard, but it's imperfect. At 3 months post-SABR, we're expecting pseudo-progression, and that's often noted, so avoid a CT scan until 6 months. And contrast enhancement is not recommended to evaluate response, which is different to thermal ablation. So at this point, I think we need, as a community, need to be invigorated by the data that we have for renal cell carcinoma and really consider about a randomized trial of SABR versus surgery. This would be a massive undertaking, but I think the time is ripe for us to be designing as a community and executing such a trial. So from my perspective, I think the future is actually here, and that SABR is ready for prime time, and it is something that we can be quite confident based on the data that we have available for us to roll this out into the clinic. It's at this point that I'd like to thank you for your attention, and I'd like to call on my colleague, Dr. Chad Tang from Texas, to come and take over and talk about metastatic disease.